One comment about age is that as much as stroke risk increases with age, and it's way more common after age 65, it can occur at any age, including children, unfortunately. So one should never ignore a stroke symptom just because you're young. And one of my most dramatic success stories was in a 26-year-old about a decade ago, where I did mechanical thrombectomy and he completely regained his paralyzed left side. But that, because he was recognized early and was brought in as a stroke.
This is the Public Health Insight Podcast.
Hello, Public Health Insight listeners. My name is Ben, and I'm here with Gordon, LaShawn, and a special guest who will be introduced later. Before we move on, it is important to note that the views expressed in this podcast are our own and do not represent any of the organizations we work for or are affiliated with. More than 13.5 million people suffer from a stroke worldwide, with strokes being the fourth leading cause of death. We often think as public health as being solely focused on implementing broad environmental approaches to improve the social and physical environment, promote healthy behaviors, and make healthy choices the easier choices. However, in the case of stroke prevention, a crucial role of public health is to promote health systems interventions to more effectively deliver high-quality preventive services. To discuss some of these innovative medical interventions to improve the health outcomes of patients experiencing a stroke, we have the pleasure of speaking with someone who is at the cutting edge in their field. He is an interventional stroke neurologist in Miami, Florida, and is affiliated with multiple hospitals in the area, including Jackson Health System, University of Miami Hospital, Miami Veterans Affairs Healthcare System, and the University of Miami Hospital and Clinics. He received his medical degree from Seth GS Medical College and has in practice for 23 years. He is here to provide his expertise regarding strokes, as well as discuss his role and initiative as the chair of the Society of Vascular and Interventional Neurology's global campaign called Mission Thrombectomy 2020+. This initiative is leading a no-holds-barred charge to accelerate access and remove geographical disparities to mechanical thrombectomy, an interventional treatment for a common type of disabling stroke. Please welcome to the Public Health Insight Podcast, Dr. Dileep Yavagal. Welcome.
Thank you so much. A real pleasure to join you.
Awesome. So before we dive into discussion of your initiatives, we wanted to talk about the context of strokes for our audience who may not be familiar with the issue. So if you don't mind, what exactly is a stroke and why does it have a public health significance?
Great question. The word stroke was coined in order to characterize what actually happens to a patient when they get a stroke, which is a sudden change in their neurologic outwardly appearance, like getting paralyzed on one side. And the fact that it happens suddenly is why the namers called it a stroke. It's like a lightning of stroke. Mm-hmm. And it actually, though very appropriate when you think about it this way, causes a lot of confusion as to what actually it is, and to some extent really needs a change to the more modern term brain attack. So the pathology that happens is either a sudden blockage in the artery one of the arteries, I should say, going to a part of the brain, which is the more common type of stroke, occurring about 85% of the times. And about 15% of the times, it's one of the vessels bursting in the brain and causing bleeding. Both these events manifest as a part of the brain not functioning, and the most common and the widely recognized symptom is paralysis on one side. But then there are other very important, less dramatic symptoms, which are easy to remember with the acronym BFAST, sudden loss of balance with a B, sudden loss of vision or difficulty with vision with E as an I, and then F as a sudden deviation or drooping of the face with the acronym letter F. And then A for arm, that suddenly starts to fall down or be weak. And then S is for a sudden speech change or difficulty. And then the T is actually for time, is of the essence, and call 911. And so these are the outwardly symptoms that occur when a stroke occurs. So that's in a nutshell what a stroke is.
From the research that we've done, stroke is a leading cause of death, and it leads to a lot of serious long-term disability as well. As quoted by the CDC, there's roughly 800,000 strokes that occur each year, and the estimated healthcare cost due to stroke is $104 billion, approximately. So with stroke being such a time-sensitive disease, what can we do from an intervention point, either proactively through public health measures or within the healthcare system, that we should be looking into?
Again, another superb question. And remember, these are only US figures, which obviously is our primary concern as being in the US, but the total burden which you mentioned is several-fold more. But that is a reason for us to design systems that can handle the occurrence of this disease and delivery of very effective therapies now that are now available. The challenge is that we have to reverse hundreds of years of nihilism towards stroke, because we really couldn't do much until 1996, where when the first medication called the clot busting medication, commonly or known, or the pharmacologic name TPA, was approved by the FDA, and it's given via vein. And then only in 2015 did the approval of mechanical thrombectomy, which is the primary focus of MT 2020 plus, come to the fore. And this change is quite recent and quite sudden, if you want to characterize it that way. And the challenge is that because the treatment is so time sensitive, it needs to be delivered within 4.5 hours for the intravenous clot busting medication, and within 24 hours for mechanical thrombectomy. And what that means is that there is a real need for triaging the right patients to the right hospital in the right frame of time. And again, the outcomes are, even in that time frame, are better when the surgery or the medication is given earlier. And so these systems are something like trauma systems, or like systems that have been designed for heart attacks. But without that system, access to this care can be quite delayed, and the patient can actually not end up getting any care because they fall out of the window.
So for people listening that might say, this stroke sound like a very complicated thing. I'm in my 40s. This doesn't really affect me. So I'm wondering if you could talk a little bit about some of those, the risk factors, whether it's modifiable or the unmodifiable risk factors that people should be aware of that can increase the risk of having a stroke.
Absolutely. So the unmodifiable risk factors, which again are something that in the future we could end up modifying, but our age and in the male gender is affected more at an earlier age as compared to women. Ultimately, women have more strokes; they live longer. And the other non-modifiable factor is family history or genetics. But having said that, I think these factors give us a idea of when to start focusing even more as you age, as once you have a family history of stroke, and depending on your gender, that you are at a higher risk of stroke. But having said that, one comment about age is that as much as stroke risk increases with age, and it's way more common after age 65, it can occur at any age, including children, unfortunately. So one should never ignore a stroke symptom just because you're young. And one of my most dramatic success stories was in a 26-year-old about a decade ago, where I did mechanical thrombectomy and he completely regained his paralyzed left side. But that, because he was recognized early and was brought in as a stroke, But the modifiable risk factors are obviously the ones that all of us should focus on, and they are high blood pressure that should be detected and controlled right away, high blood sugar, so fasting blood sugars need to be checked, a condition called atrial fibrillation increases your risk of stroke fivefold. It is irregular heartbeat. And so that is something that is silent. The vast majority of the times you cannot feel any palpitations or any irregularity unless your doctor checks for it. So again, regular checkups. And then very heavy alcohol use is a risk factor. Drugs are a risk factor, cocaine, like drugs, and even several other hard drugs. And then sedentary lifestyle and obesity are now well established to be risk factors for stroke. And so all of these, and then there are some other genetic syndromes, but they fall again in the non-modifiable category. So these are sort of the main, and smoking, I forgot a very, very important risk factor there. Smoking increases your risk manyfold. And that is something one has to absolutely quit right away to prevent the future risk of stroke.
Yeah, very interesting. Another thing that came to mind is, are there any risks associated with like social, economic, or environmental risks?
Yeah, so certainly, these are factors that are being worked out now. Air pollution is definitely a risk factor that's getting proven in multiple studies again and again. A lower socioeconomic demographic does bring in a host of factors that ultimately seem to increase the risk of stroke and having long-term effects of stroke more than if you were in a higher socioeconomic and educational category. So these are certainly risk factors that are now being worked out as increasing our risk of stroke. And I forgot one other important factor, which is race and ethnicity. So African Americans are several-fold, and this is a non-modifiable factor, but they are several-fold at higher risk as compared to whites, as are and below African Americans or Hispanics, they have a higher risk of stroke as compared to whites.
Yeah, one of the interesting things I find when we're talking about these conditions is that often, for example, a stroke or dementia, they're often associated with age, and as you mentioned, that was one of the uncontrollable risk factors. And oftentimes people chalk it up and say, this is just something that happens when you get older. But how can we shift that narrative to show them that a large percentage of strokes that occur are indeed preventable?
Yes, it's absolutely true that the vast majority of strokes, even at an older age, are preventable because we have interventions for intervening in the mechanisms of stroke. And just to get into a little detail about this so that we all understand, the reason the blockage kind of stroke occurs is a clot comes up and blocks an artery in the brain. And a smaller percentage of the times there is plaque buildup in one of the arteries of the brain, and then a clot forms on top of that plaque all of a sudden due to various processes, and the artery gets blocked. But the way this mechanism can be modified, as you can imagine, is to prevent the source of clots, which is often the heart. And sometimes we can't find the source, but again, the clot formation can be decreased by being on blood thinners and avoiding smoking and high blood pressure. And then the other source of blood clots is plaque buildup in the arteries in the neck, like the carotid artery. And so again, measures to decrease cholesterol and high blood pressure prevent that. And of course, medications called statins are very powerful in preventing this plaque buildup. So these are all factors that can be blocked in this mechanistic pathway, thus reducing your risk of stroke. So while this all happens with age, you can break this chain and decrease your risk of stroke. The other type of stroke is the bleeding kind of stroke, also called hemorrhagic stroke, and that results from a very high blood pressure, which can be very well controlled now in the vast majority of patients. The biggest thing is it's a silent killer, so it needs to be detected. As soon as your late 20s or early 30s, regular checkups can pick it up, and that can be modified. And then heavy alcohol use is a big risk factor for hemorrhagic stroke, as is smoking. So all these are because they affect the vessel wall. And so while age is something that we can't counter, all these other additive factors are what can be modified and countered. And so we should really realize that this happening of stroke as we get older is not inevitable and can be prevented.
What prevention plans have existed historically? I know you touched upon TPAs, but on top of that, what else has happened with setting up a stroke system?
Yeah, so as soon as TPA was approved, there was a big push from the American Heart and Stroke Association, AHA, ASA, and several other stakeholders, including a governmental bodies, including health departments, to deliver this very powerful therapy. The efforts did bear fruit, but the 4.5-hour window is so tight that it took almost a decade and a half to get the access up from about 2 to 3% to around 10% or so, even in the US, and much less around the globe, where the resources for such systems for rapid triage are way lower than what we have here. But that has become significantly easier, and I use the word easier in a very relative term, because TPA systems, which are delivered by centers that are certified as primary stroke centers, were the solution that existed. But mechanical thrombectomy extended this window to 24 hours as of 2018. The first extension was 6 hours, and then the next extension happened in 2018, where it was extended to 24 hours. And what happened is that a new category of centers needed to be certified, called thrombectomy stroke centers, or comprehensive stroke centers. So that has been a major push from the Joint Commission to get centers certified as comprehensive stroke centers, and then more recently thrombectomy stroke centers, so that we can designate the transport of suspected stroke patients from the field to the correct center, and these can be distributed geographically in a equitable manner, so that patients can get to these centers within the hour and even earlier. However, this is actually a much tougher task than one can imagine. And even as of 2019, only about 56% or so of the U.S. population is within 1 hour access of a thrombectomy stroke center, which really is the treatment for severe strokes, called large vessel occlusion stroke. So there's a lot of work to be done in the U.S. And if you think about what is happening in the rest of the world, especially the low and middle income countries, it's a much lower access to thrombectomy than what we have in the US currently.
Absolutely. I'm glad you mentioned that, because my next question was going to be talking about geographical disparities. And I'm glad you also mentioned middle and low income countries who may not have the healthcare infrastructure to provide these services. Do you think it's, of course, we build upon the healthcare services, but also a push for more public health measures to prevent stroke? Like, for example, if we're talking about the risk factors being diet, sedentary lifestyles, should we have more push for messaging regarding healthy, balanced diets, physical activity, and stress reduction?
I think you're absolutely right. And there is no more powerful message than showing what the end result could be if these measures are not followed. Because, the messaging, which is good, is sometimes easy to become sort of numb to or get too used to, and easy to ignore when the end result is not clarified or clear when the messaging is done. And so I think saying that this is a powerful way of preventing being disabled for many years is the kind of messaging that is needed throughout the world. And it's harder in lower resource settings because people have to spend their time, earning their living, and that certainly takes away from the time needed to exercise and find healthy foods. So there's just obviously a lot of science behind this that I am not an expert at, but certainly I think the messaging part is very important, and I'm a strong advocate that this preventive message needs to happen with more and more refined strategies and on a constant basis.
Yeah, I definitely appreciate that approach because, while you're one of the leading experts in your field for medical interventions for strokes, you also recognize the value of prevention. And we have, when we talk about prevention, there's, primary prevention, which deals with, addressing those modifiable risk factors. Secondary prevention deals with more early detection. And you alluded to, if you have high blood pressure, it's something you want to be screened for and have it treated early before it becomes a chronic problem. And then the tertiary level of prevention for people who are at the point where they need those critical interventions that they do have access to it. So I think tying everything together and focusing and realizing all the importance of all these different levels of prevention is essential to treating, preventing strokes and then preventing some of those negative outcomes associated with people that have strokes. So I very much appreciate that take on everything.
Absolutely.
This was our discussion about strokes, the warning signs, and risk factors with Dr. Yavagal, a world-renowned interventional stroke neurologist. To learn more about his initiative called Mission Thrombectomy 2020+, and how he is working to accelerate access to crucial stroke interventions, please join us for part 2 of this informative conversation next week. Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations inspiring community action. If you enjoy our content and would like to stay up to date, follow us on Instagram, Facebook, Twitter, and LinkedIn. To learn more about our community initiatives and how you can support us, visit our website at thepublichealthinsight.com. Join the PHI community, and let's make public health viral.